What if I'm asked to prescribe for another staff member, such as a physician associate or a specialist nurse by my department? As ever, really good question submitted by someone that will be joining us in August as a new doctor. Particularly in this case, I have to preface this video by saying this is not professional or legal advice and does not constitute that. It represents purely my own thoughts, my own opinions. This is what I would have to say in response to this question. If you come into this situation, you need to seek advice from your local trade union representative, from your supervisor, and from your medical indemnity provider. So basically the rub of the question is, what if I'm asked to prescribe on behalf of someone else? So the ethical, moral, legal, whatever question is about using your prescribing powers as a qualified doctor on behalf of someone else, or to achieve something that someone else wants to achieve. And I think we should start by acknowledging that there are good, genuine reasons why someone might want this to be the case. If, for example, as was given in the question, you have a medical associate professional, such as a physician associate, a PA, or an anaesthetic associate, an AA, and they are going about their routine tasks and jobs, they are at present unable to prescribe in their role, so it becomes reasonable that they will need to ask somebody for assistance with that prescribing, somebody who has prescribing powers. To give a different example, a ward or a department will commonly run a specialist nurse clinic, say, but that specialist nurse may not be a prescriber, and they might manage something like heart failure or recovery after surgery or diabetes or something. And if again they are a non-prescriber, then any recommendations that they make about medical treatments would need to be prescribed by a prescriber. And the simplest possible version of my answer on how to think about this, as per the GMC, basically, is that you are responsible as a prescribing doctor for any prescription that you sign that puts your name and GMC number to it. If something goes wrong, such that the patient has an allergic reaction to it when they were allergic to the medication you prescribed, or it interacts in some deleterious way with something else that they are taking, and that leads to harm, then you are the one who is going to be answering questions about it. So firstly, I think before I continue, I'm going to link the GMC guidance on prescribing, because they do address situations like this, and obviously being aware of what the regulator has to say is the most important thing to read, because that is the standard against which we are measured. So if you want, stop the video, go ahead and read what is linked in the description. My own personal view on this is perhaps a bit more nuanced than the high-level guidance, and that simply comes from having worked, obviously, as a new foundation doctor, but especially for more junior doctors, such as foundation doctors, perhaps core trainees. You are at that level in a situation where you should not be prescribing unseen for patients, because you are not able to take sole responsibility for that patient. The bottom line is that all doctors, and in fact all prescribers, have a duty to review and examine any patient for which they are prescribing anything, and as we've said before, they are ultimately responsible for any prescription they sign. It's important to remember that prescribing is not a benign act. Obviously that's why it's so closely regulated and why people have to be trained specifically to do it, so that they know how to use their prescribing right. And you can cause damage in even very kind of innocuous way. Even some of the simplest things that we prescribe, for example things like paracetamol and ibuprofen for simple analgesia pain relief, you still have to think about these prescriptions even though they seem very innocuous. Are these medications suitable for that patient in the dose and form that I prescribed them in? How is their hepatic or renal function? Is there a more rational alternative to what we're prescribing? What is the mechanism of action of what those drugs are doing? What is the mechanism of action of the pain that we are trying to deal with? What are we actually trying to achieve with this intervention, and is it justified, weighing up the risks and benefits? Because it's my name that's going on that dotted line, I want to have thought about these things. So in the event that another member of the team comes to you and says, you know, look, I've examined Mr. Smith in bed 7 and I think he needs antibiotics, could you please prescribe them? You are definitely going and reviewing that patient yourself. And these situations are unfortunately fairly common, but they're not okay, especially for those most early careers doctors. And the reason why I'm making this video at this time is that if you are a new foundation doctor, even a foundation year 2 doctor I would argue, and you're working as an SHO, it is not fair or reasonable for a department to ask you to absorb risk in this way from another medical professional. Does this duplicate work? Yes. Is that your problem? No. My feeling is that if people are going to be deployed and employed in the NHS in these kinds of roles where they might make recommendations where prescriptions need to be generated as part of that, then they should have proper indemnified policies in place to do that and to keep patients safe. It is not fair or safe or reasonable to simply move that burden of risk to whoever the nearest prescriber happens to be. It is not your responsibility as a new doctor to take that burden of overseeing other members of staff who you are not capable professionally of overseeing. So my preference, for example, would be if I was asked to do something like this, I would say, no, I'm sorry, I'm not comfortable with that. Please speak to whoever your supervising consultant is, or perhaps the senior registrar, someone who is experienced enough and capable enough to actually act in that kind of capacity and absorb that medico-legal risk. If you raise this as a problem, will the senior doctors in the department or someone in the department complain? Yeah, they might do. And if this happens, and it may happen, this is a position where you and your fellow new doctors need to be really strong and stand together. Your line manager, your supervisor, your union representative involved early. This needs stamping out as an expectation, especially if it's presented to you guys early before you're settled in. And to revisit what I've said before, if a department wants to run in such a way that non-prescribers are making recommendations that will need a prescriber to action, then they need to have proper regulations and procedures in place to allow that to happen. And whoever those supervisors are going to be that takes that risk needs to be properly trained, insured, and indemnified in case things go wrong. And what is clear is that the most new and junior doctors on the team are not going to be those people. And as I just hinted, the danger is that new doctors who are joining us in the NHS are going to be the most vulnerable to this kind of behaviour where they don't necessarily know what's normal. If you're a bit more of a senior doctor or a bit more experienced and you find out that this is happening, please stand up for your colleagues and try and stamp it out or find an alternative provision. It is not acceptable behaviour. And those of us that can recognise this for the bad behaviour and bad expectation that it is, have a duty to call it out and to try and make things change. Thanks very much for watching, guys. Please be sure to hit that like button for me, leave a comment, subscribe, and I'll see you next time. Bye-bye.